My name is Gabor Zilahi, and the aim of this presentation is to guide you through the sequence of a focused transoesophageal echocardiography examination for a critically unwell patient. We will discuss the knobology of the TOE probe, basic transducer manipulation, the advantages and disadvantages of TOE, and most importantly, I will demonstrate the 12 essential TOE views that can significantly enhance your cardiac and hemodynamic assessment in critical care settings. Before we begin, I want to highlight a few important papers. First, the International Consensus Statement on Critical Care Echocardiography, published in Intensive Care Medicine in 2014. This paper emphasizes the importance of critical care echocardiography, outlines the necessary competencies, and specifies the required training for both focused TTE and TOE in intensive care. The most comprehensive and foundational TOE guideline remains the ASE guideline published over 10 years ago by the American Society of Echocardiography. It summarizes key recommendations, available views, and measurements critical for comprehensive TOE examination. On the right, you can also see the BSE guideline, which is another valuable resource if you're interested in this topic. Let's move on to knobology. Every TOE probe has two wheels, a small wheel on the top, which moves the probe tip left or right, and a large wheel, which controls anteflexion or retroflexion of the tip. To lock the tip in position, you can use the brake button. However, caution is necessary as improper manipulation while the lock is on, especially in the esophagus, can be dangerous. Additionally, there are two small buttons on the side of the TOE probe that rotate the ultrasound beam from 0 degree to 180 degrees. These are called the array rotation or omniplane buttons, functioning similarly to the clockwise or anticlockwise rotation of a TTE probe. Regarding probe manipulation, the TOE probe can be advanced or withdrawn into the patient. It can also be turned to the right or left. The small and large wheels, as mentioned, control the tip's anteflexion, retroflexion, and lateral movements to the right and left. Pressing the small buttons rotates the ultrasound beam clockwise or anticlockwise up to 180 degrees, mimicking the rotational movement of a TTE probe. Before we dive into the basic views, let's consider some advantages, disadvantages, and contraindications of transoesophageal echocardiography. In general, TOE offers a shorter training period, superior spatial resolution, and is better than TTE for specific diagnoses such as endocarditis, valvular dysfunction, and aortic dissection. It is also less operator dependent in theory. However, TOE has its downsides. The probe requires strict cleaning protocols, is invasive, and can cause trauma or injuries anywhere from the lips to the stomach. The examination may not be well tolerated by patients, often requiring sedation, which can compromise the airway and breathing. The most serious complication, esophageal perforation, has a high morbidity and mortality rate and occurs in approximately 1 in every 3,000 examinations, according to recent studies. There are a few absolute contraindications to TOE, as shown on the left side of the screen. These include esophageal or gastric perforation and active upper GI bleed, to name the few. The list of relative contraindications is longer and should be carefully considered alongside other patients' factors to minimize the potential risks of the procedure. These are the 12 basic TOE views we will cover in the next few minutes. They are based on the International Consensus Statement on Critical Care Echocardiography, which also forms the foundation of the European Diploma in Advanced Critical Care Echocardiography, or EDEC. However, a comprehensive TOE examination includes over 25 views as outlined in the ASE guidelines, which define the sequence and structure of a thorough examination. There are 4 key levels in the esophagus and stomach for obtaining ultrasound windows: the upper esophageal, mid-esophageal, transgastric, and deep transgastric levels. At each level, the omniplane can be rotated between 0 to 180 degrees, enabling both short axis and long axis imaging planes. The first and most important view is the mid-esophageal 4-chamber view. Insert the probe approximately 30 cm from the lips, with a sector depth around 15 cm and an omniplane angle of 0 to 10 degrees. The goal is to visualize all 4 heart chambers. To optimize the LV apex, use slight retroflexion of the probe tip. Ensure that no part of the aortic valve or LVOT is visible, and aim to maximize the tricuspid valve diameter while adjusting the depth to display the entire left ventricle. The probe is positioned behind the left atrium, so the imaging plane is directed through it. This view captures a snapshot of the heart, including all 4 chambers: left atrium, left ventricle, right atrium, and right ventricle. 2 valves, the mitral and the tricuspid, the intraatrial and the intraventricle septae. The inferoseptal and anterolateral left ventricle walls are also visible. It is primarily used to assess LV and RV chamber size, LV and RV function, mitral and tricuspid valves, atrial and ventricle septa, and pericardium. From the mid-esophageal 4-chamber view, rotate the omniplane angle to 80 to 110 degrees to transition to the mid-esophageal 2-chamber view as visible on the screen. The right atrium and the right ventricle will disappear. Optimize the view to capture the true left ventricle apex with a small adjustment. And if the left atrial appendage needs to be visualized, the probe should be slightly withdrawn. This view is orthogonal to the mid-esophageal 4-chamber view, displaying the anterior LV wall on the right and the inferior LV wall on the left. It is used to diagnose LV size and function, LA abnormalities, mitral valve disease, LAA masses or thrombi. By further rotating the omniplane angle to 120-140 degrees, you will visualize the mid-esophageal long axis view, which highlights the aortic valve and the LVOT. The RV reappears on the right side of the screen again. Ensure that the true LV apex is captured. By withdrawing the probe, focus will be more on the aortic valve and the LVOT. This view is ideal for imaging the aortic root, aortic valve, LV, mitral valve, and the left atrium. The LV anteroseptal wall appears on the right, while the inferolateral wall is on the left of the screen. Use this view to assess the LV function, left atrial and mitral valve abnormalities, aortic valve function, and the aortic root. From the mid-esophageal long axis view, withdraw the probe slightly and adjust the omniplane angle to 30-45 degrees. Reduce the sector depth to 5 to 6 cm to optimize the image. The aim is to center the aortic valve on the screen, ensuring its 3 cusps appear symmetric. Withdraw the probe to visualize the coronary ostia or advance it to focus on the LVOT. As mentioned before, at the mid-esophageal level, the ultrasound beam passes through the left atrium and is aligned parallel to the AV annulus. The 3 aortic cusps should appear symmetrical. The non-coronary cusp is adjacent to the intraatrial septum. The right coronary cusp is most anterior, next to the right ventricle. The left coronary cusp is adjacent to the left atrium. This view is particularly useful for assessing aortic valve disease, the intraatrial septum, and the left and right atrium. Adjust the omniplane angle to 60 to 75 degree and increase the sector depth to 10 centimeters to obtain the right ventricle inflow-outflow view. Ensure the tricuspid valve leaflets are visible and that the RVOT, pulmonary valve, and the main pulmonary artery are clearly displayed. The structures closest to the probe remain the left atrium, followed by the aortic valve. On the left of the screen, the right atrium and tricuspid valve are visible, called the right ventricle inflow, leading into the RVOT, or right ventricle outflow tract, and the pulmonary valve on the right side of the screen. Beyond the pulmonary valve, the main pulmonary artery is seen. This view is used to assess the tricuspid valve, right ventricle function, RVOT and pulmonary valve, and also to guide the pulmonary artery catheter insertion. The next view is the bicaval view. To obtain this, adjust the omniplane to approximately 90 to 100 degree and turn the probe to the right. Depth adjustment may be necessary. Rotate or change the angle slightly to image both the inferior vena cava on the left and the superior vena cava on the right. A small omniplane angle change to approximately 120 degree will bring the tricuspid valve into the far field for Doppler measurements, and this is the so-called modified bicaval view. In this bicaval view, the left atrium appears at the sector apex, the right atrium in the far field, the IVC on the left, and the SVC on the right. This view is valuable for assessing central venous catheter positioning, ECMO cannulation, fluid responsiveness, and of course, the intraatrial septum. Moving to the upper esophageal view, reduce the omniplane angle to 0 degree. Rotate the probe until the aortic valve is visualized, then withdraw it by following the ascending aorta. The main pulmonary artery will appear in the middle of the screen with its bifurcation at the top. Depth adjustment may be necessary, but tracheal artifact can make this view challenging or impossible to obtain. In this view, the imaging plane passes through the right pulmonary artery, ascending aorta, and SVC. The main structure in the center is the main pulmonary artery, with the tricuspid valve may also be visible at the far field. This view is useful for assessing the SVC, the ascending aorta, and the pulmonary artery. Next, we move to the transgastric and deep transgastric views. Set the sector depth to around 10 cm and keep the omniplane angle at 0 degree. Advance the probe past the mid-esophageal four-chamber view until the left ventricle appears in a short axis view as shown on the screen. Use the anteflexion to bring the stomach wall into contact with the inferior wall of the heart for better resolution. Center the LV by turning the probe left or right, ensuring both papillary muscles are visible. In the transgastric mid-papillary short axis view, the imaging plane is directed transversely through the inferior left ventricle wall. The septal wall is on the left, the lateral wall on the right, and the anterior wall in the far field. By adjusting the probe, usually anteflexion and retroflexion, you can visualize all three left ventricle levels for a complete wall motion assessment. Rotating the probe left or right also allows for right ventricle and intraventricular septum evaluation. This view is useful for assessing LV size and function, intraventricular septum abnormalities, and pericardial effusion. By increasing the omniplane angle to 110-130 degree, you will transition to the transgastric long axis view. The sector depth may need to be increased to visualize the LVOT and the aortic valve on the right side of the screen. In the transgastric long axis view, the imaging plane is directed longitudinally through the LV to include the aortic root. The LVOT and the aortic valve appear on the right side of the screen. This view is similar to the mid-esophageal long axis view, but allows for spectral Doppler assessment through the LVOT and aortic valve, enabling measurements like stroke volume estimation. It is also useful for assessing subvalvular mitral valve apparatus, the interventricular septum, LV size, and function. Our final transgastric window is the deep transgastric view. Reduce the omniplane angle to 0 degree and advance the probe until the LV disappears. Anteflex the probe until the LV apex appears again at the top of the display. Additional anteflexion will bring the LVOT and the aortic valve into view. You may need to flex the tip to the left or rotate the probe slightly to center the LVOT and aortic valve on the screen. In this view, the imaging plane passes from the LV apex back through the base of the heart. On the screen, the ascending aorta with the aortic valve is at the bottom, the left atrium is in the middle, and the LV and RV are closest to the probe. This view is valuable for Doppler-derived velocity measurements across the LVOT and aortic valve and is particularly useful for stroke volume assessment. It is also used to diagnose aortic valve and LVOT gradients. The final two windows are the short axis and long axis views of the descending and abdominal aorta. To obtain these, rotate the probe approximately 180 degrees toward the spine, keeping the omniplane at 0 degree. Reduce the sector depth to about 5 cm to visualize the descending aorta from the distal arch down to the abdomen, where it eventually disappears. The omniplane is increased to 90 degrees. The short axis view transitions to the long axis view. These two views are particularly useful for assessing aortic diseases such as dissections, hematomas, or plaques. They are also helpful for intra-aortic balloon pump positioning. These were the 12 focused windows that aid in cardiac and hemodynamic assessment. As you've seen, I've presented them in an order I find logical and practical, but the sequence can be individualized based on patients' needs and the investigator's preferences. To recap, we have covered the mid-esophageal 4 and 2 chamber and long axis views, the short axis view of the aortic valve, the mid-esophageal right ventricle inflow-outflow view, and the bicaval view. Then we moved the probe into the upper esophagus to assess the ascending aorta and the pulmonary artery. Then we moved the probe down into the stomach for the transgastric short and long axis windows, and further down for the deep transgastric window. For a 180-degree turn, we arrived to our last two views, the aortic short axis and long axis views. In summary, transoesophageal echocardiography remains an excellent tool for cardiac and hemodynamic assessment. It provides superior spatial resolution and is diagnostically better than TT for specific conditions. However, it is invasive and not without potential complications. Thank you very much for listening.